Welcome, everyone. My name is Karen Lee, and I would like to welcome you to the California Improvement Network webinar, the Ambulatory Intensive Care Unit, Early Experiences, Progressive Partnerships for Change. Just a little about the California Improvement Network. It is a partnership between the California Healthcare Foundation and 8 partner organizations around the state to support spreading improvements in chronic disease care. We host these monthly webinars on timely topics related to improving clinical quality, patient experience, and or reducing the cost of care. And today's presentation will address all 3 of these areas. Since there are many people joining the webinar, everyone has been muted. If you would like to ask a question, please raise your hand. And I will unmute your line. I think the raise hand button is towards the middle right of your screen. Or you can send me questions through the chat function. We have planned for there to be about 20 minutes of Q&A after the presentations. And you're welcome to send your questions throughout the presentation, but we most likely will hold most of them until the end of the webinar. I'm delighted to introduce our speakers today. They are Dr. Pranav Kasari and Ms. Jolene Rogers. Dr. Kasari has spent his career in clinical and service process innovation, developing ideas for more affordable, higher quality health care. He is founder of Renaissance Health, which is an organization focusing on the design and implementation of innovative healthcare delivery and financing models. Dr. Kasari is a lead developer of the Ambulatory Intensive Care Unit. That is the concept that is being implemented with large entities across the U.S. Ms. Rogers is the Special Project Manager at the Everett Clinic with a focus on education, training, and support for nurse care managers. She was the nurse care manager and project manager for the Boeing company's 2-year pilot of the intensive outpatient care program, which you'll be hearing about today. And she has been an ambulatory care nurse for 11 years. So without further ado, I will turn it over to Dr. Kasari.
Thanks, Karen. And I'll use Karen as a test point. Can you hear me okay?
Yes, I can.
Perfect.
And if anybody can't, please raise your hand.
So appreciate everyone joining today, and I think hopefully a topic of interest, and certainly a topic that fits well and squarely within all of the conversation going on within California and nationally around the urgency and need for healthcare reform, and more than just health insurance reform, but actually care design reform as well. And so today we'll talk about what we've called the Ambulatory Intensive Care Unit, and we'll talk a little bit about the origins and then some of the implementations of it. There is a lot of material, and so I'm going to go fairly briskly through it in order to leave time for questions, and you'll have our contact information as well if you want to reach out separately as well. But I think there's some rich information that I'd like to get through, and Jolene has a lot of great information about the care manager role as well. So Einstein always kicks me off with insanity is doing the same thing over and over and expecting different results. And really, for all too long in healthcare, we've tried that for decades. Really, we've been delivering care the same way and hoping that we get higher quality, better patient experience, and lower cost. And we really haven't changed much of what we do to impact that to happen. So today we'll highlight some of that imperative for care process innovation. I think things that you probably know. We'll talk about the AICU model, and we'll talk about Boeing's implementation of that model, and it was called the Intensive Outpatient Care Program. And finally, we'll focus on what probably is the most critical element in this care model, which is the role of the care manager, and some experiential lessons there. As Karen said, Renaissance Health is a company that designs and implements new models of care. And one of our emphasis has been around creating affordable care models. And we think a lot of that starts and ends with partnerships between purchasers and providers and patients. And so we focus that in all of our work. This story you know well, the current model of care built around 10 to 15-minute visits, long waits to get an appointment, industrial look physical space, really under-prioritized customer service, mostly reactive care, not much proactive care. Patient records kept on paper charts still in a lot of cases. Physician panel sizes that seem really large, and the recent articles in Health Affairs and elsewhere has shown that physicians with these panel sizes are doing insurmountable amounts of work compared to what our expectations should be in a 40, 50, or 60-hour work week. And finally, the system probably least well serves the people most in need, those who have complex and chronic conditions. The other paradigm that's really happening is we're really overstretching our primary care workforce, and we're starting to feel that as providers leave the field earlier and earlier in their careers. And then at the frontline staff, we have a highly rotating frontline staff, unlike other service industries. And then on the healthcare spend side, almost a 10% annual rise since 1970, with health insurance premiums rising faster than wages. And particularly in low-wage workers, that's sort of increasing the stress and moving towards higher levels of uninsured. The net here is it's an unstable and unsustainable system, and as Don Berwick would say, we're carrying the 19th century clinical office into the 21st century, and it really is time to retire it. So what have we done? We've tried to do some things, but most of them have been sort of incremental change. So this, let's pay a small P for P that helps to drive one element in diabetes care, or some smaller aspect of change that often is overwhelmed by the status quo and it's difficult to sustain. We do our PDSA cycles, and there's, I think there's great work there in being nimble and challenges in having it be sustainable. Occasionally we, and from a provider perspective, and I'm a primary care provider by training, it's viewed as ad work, so do group visits, do email with our patients, all the right things to do, but how do we fit them into the day, and how do we make them financially sustainable? And so we say maybe it's through technology, and there's a huge national movement and IT infrastructure budget built around electronic health records. And I think we know that there is reason to think that they will lead to good quality care and more consistent care. But I think there ought to be some caution in recognizing that the tool itself is not the answer. It's the implementation of the tool. And we need to think about the models to implement those sort of tools. And then finally, from a primary care perspective, we've sort of underperformed for so long that we've created entire industries that wrap around us. Disease management and case management. And last we checked, that was our job, to manage disease. And so I think there's opportunity here, even in moving way beyond these small changes. And so I often think back to a little over a century ago, how transportation looked, and we were sort of limited by the speed of trains and the tracks that we were built on, and we had the boats that could take us across the Atlantic. But really, no matter how much we well tuned the engines and how well we studied the waves and had the navigation systems on our sails working right, we really couldn't make a leap, a discontinuous leap, if you will. And what we really needed was a game changer, and that was the airplane coming. And I think one of the things that doesn't go told in the story is that the Wright brothers were one of many, of course, who were working on developing the airplane. I think similar in healthcare, we have lots of different initiatives going on. But the real story is that so many of them fail along the way, and it's the persistence of movement that allowed us eventually to have sustained flight and create a whole different paradigm in transportation. And I think it's the same thing here in healthcare, that we need to have some sustained momentum, some intentional approaches and intentional investment towards it. And there really is an imperative right now for us to move boldly, move quickly. As we just discussed, the current model really is not sustainable. We need to really test completely different models of care. And when you think about why it hasn't been sustainable, and we look at the providers, the plans, and the purchasers, having been unwilling or really unable to do the redesign alone. So this silo-based reform just doesn't really work. So we can't make the right changes given the current payment system. The incentives don't align. Sometimes we don't recognize the need for change through the lens that we may be looking at it for. In some cases, there's unwillingness to change, so things are working just fine for one perspective. It's difficult in sort of our complicated healthcare system to move the change. And then finally, I think there's fear that the change may hurt them. But we do have currently, I think, a lot of shared pain points, and there's an opportunity to really synchronize all of our stakeholders. And the key is in that synchronization, and we think that the key to successful, sustainable innovation is more rational systems of care coupled with reimbursement transformation. So change the way we deliver care, change the way we pay for it, and you can do that through strong payer-provider partnerships. And that really will allow us to achieve what we call triple aim plus, and that's borrowing from Don Berwick and IHI around their triple aim, and we add a couple things here. So, of course, improve the health of the population, enhance the patient experience of care. The next two bullets are a little of the plus, which is improve the experience of our provider teams, our workforce, increase the patient self-efficacy, motivation, and productivity. And then finally, and I think there's an asterisk next to it because many of us would put this at the very top in today's current environment, but we need to reduce or at least control the per capita cost of care. And that can lead us to this quadruple win. Patients get better care and a better experience. Providers feel that their work lifestyle is sustainable and that they're getting rewarded for the right things. Purchasers and plans are getting efficient, high-quality care. And we think that there's a way to do that, and one of those starting points is really in the ambulatory intensive care unit model. So I'll start to describe this model and then how the Boeing model fits into this. But this really has roots probably even before 2003, where there was thinking from Mark Smith and Sophia Chang and others at the California Healthcare Foundation that we really need to develop disruptive new models of delivering care as a strategy for dramatically reducing premiums while maintaining or improving quality. And part of the insight was that as a country, we have so many uninsured individuals, and as a state, certainly California does, and we probably just don't have enough generosity of resource to just cover them. So if you just put it in quotes and say just cover them, it's probably not something that's doable. So we really need to find it within the resources that are there. And lots of good data that shows there's a lot of excess resource spend right now in the system. And so with California Healthcare Foundation's support, Arnie Milstein, myself, Dr. Fernanda Pulley, led a group of national partners to really think about what we could do that would be a more sustainable model that would dramatically reduce healthcare costs and improve quality. And the model was called the Ambulatory Intensive Care Unit, and it focused on primary care-led, high-intensity care management. And the key was for the highest risk part of the population. So when we looked at the whole population, that in a lot of ways, the concentration of the need in terms of disease burden and the expenditure in terms of the per capita expense in healthcare was focused in a very small part of the population. And we thought that with a focus intentionally on care models designed around them, there was a significant opportunity to reduce costs as much as 25 or more %. And we had some independent technical experts sort of look at the financial projections around that. And so the first step here was really choosing the target wisely. And I think a lot of times we have to really look carefully at the different components of the care we need to deliver. So for the healthy folks, in some ways, they're well served with wellness programs, lifestyle modification, and I would add that they need access to health care. But the intensity of the health care that they need probably doesn't match sometimes what we try to build in kind of larger primary care models. Acute minor issues, we certainly need after-hours urgent care, retail kiosks, worksite clinics, and immediate availability for care. And then simple chronic conditions can be done more in silo-based, protocol-driven. But the really complex folks, the folks who have high-cost, multiple chronic conditions, they really need a different intervention. And if you look at the graph or the chart on the right, it shows you that it's the classic 80-20. About 20% of the population incurs about 80% of the healthcare spend. And so we think that's really all about a paradigm change. So our job is to meet the needs of the patient. And this chart on the right is one of my favorites to show. The red or purple, depending on your screen, is the amount of time that a patient spends without a physician or a provider with them. And that little sliver in the middle, that 0.6%, is the amount of time in their life that they spend with a physician or a provider with them. And so it's really not us managing their health. It's them learning to manage their illness, us helping their caregivers with that as well. And so we need to build models like that. So how is care different in the AICU? So there's three different ways we look at it: new principles, new processes, and new structures. And I won't focus on all of these. I'll leave them for you to read. But in the new principles, it's really not incremental change, comprehensive redesign, and then really focus efforts on the sickest patients. And the new processes we'll come back to a little bit later in the slide deck. And then the new structures, this is really important. I think it's difficult to embed this into existing care models without some intentionality around what really needs to change. And I think you have to have the right team in place and then really work as a team. You need some amount of information technology platform. There could be some physical space design changes, and we'll talk about why. But most important is really that we need a payment model that rewards the right thing. And that would reward a culture of service and evidence-based conservatism and improvement in care. So the Boeing company, I guess 4 years ago now, embarked on looking at their healthcare costs, and as most employers, they recognized that it was unsustainable cost curve, and their largest competitor, Airbus in Europe, does not have to deal with healthcare in the same way that Boeing does. And at the time, Boeing actually still had an entirely free, zero premium plan. And unlike other employers, they hadn't moved to cost shifting at the time, and they thought that the ambulatory ICU might be a method whereby they could save enough overall healthcare costs in order to continue to maintain their benefit structures at the rich level that they were. The intensive outpatient care program was launched in the Puget Sound market, which is Boeing's largest market, and they have about 150,000 lives there. And we worked with three large medical groups, the Everett Clinic, Virginia Mason, and Valley Medical. And we selected those groups specifically on their willingness to test this model and their organizational culture and our belief that they could be successful in this. And we launched a 2-year pilot. And the model in brief: relationship-based risk case management. So this is the notion that we need to develop strong relationships and partnerships with our patients in primary care and do lots of proactive outreach with them in person, by phone, over email, and give them a personal care support team to reduce their risk for future intensive upstream care. We need to make our MD visits more efficient, and we use IT, medical assistants, the health coaches, in order to make really efficient, predictable, prepared visits. Finally, there's the supply chain management piece. So this is looking at the spend that's going to occur in specialty and hospitals and high-cost diagnostics and treatments, and what can we do to manage that upfront in primary care through relationships and risk reduction. And it starts, of course, with patient selection, and I'll leave the details of that for you to read. So I'll go to the punchline first and then move quickly through some of the elements. But in Boeing, we looked to try to achieve that AAA+, and we got very high levels of employee satisfaction. We used the Ambulatory Care Experiences Survey, and the patients had significant improvements over baseline and about 90% satisfaction in most of the metrics, with a specific significant recognition that the nurse care manager's role was the most important. We looked at functional status and worksite productivity and saw 20% improvements in SF-12 physical and mental, and significant improvements in time lost from work. The clinical quality measures that we looked at were diabetes care, high cholesterol, and high blood pressure, and the sites in almost all metrics reached 90th percentile of clinical quality compass from NCQA. Our providers and nurses provided testimonials and support of the better care that they were able to provide. We didn't do a formal survey on that. And finally, and this is sort of the $64,000 question, did it save money? And versus a matched control group, we were able to have a 20% annual savings per enrollee. So a very significant improvement. The way the clinics were paid for this was through a 3-tiered payment methodology. They were given a fee-for-service, which was their existing contractual fee-for-service, a per member per month for the care management piece, and then a shared, and then in the future we're moving towards a shared savings model. In this iteration, they didn't receive a shared savings. As we said in the other diagram, it's really looking at the complex individuals, and we think of it as the 3 Cs: people who have continuing conditions, complex conditions, and costly conditions. This just gives you a flavor of what these individuals look like. On average, 5'6", 209 pounds. You can kind of picture the folks coming into the clinic. They have multiple chronic conditions, and you'll see 2 of the top 3 are more are depression and pain, and so real complicated things to deal with, in addition to hypertension, GI disease, coronary artery disease, diabetes. And then on average, they had 3.5 of those conditions, so multiple medical conditions. So I'll go through, I think there's 5 slides here about the keys to success. The IOCP team was the key, number 1, and that element is a dedicated, intentional staffing team for this model, and so and very clear that this needs to be a dedicated program. I think shared attention for these patients in this level of intensity that's required underserves the model, and so we anchor everything on the RN care manager, which Jolene will talk about, and then we have integrated within primary care the programs that the RN care manager leads. We think the key communication piece is the strategic action plan. There's a written live document that's agreed on by both the doctors and the patients that set out priorities, plans, and clear goals for the project. And it's really negotiating a ranked order list of issues and then having a clear plan as to exactly how the patient and the care team will work together on them. It's giving patients better access, so in-person advanced access, minimizing wait times, giving them direct phone access, and then real important is providing them email. And what we learn over time is about half of the provider's time will end up being non-visit based if this is managed right. There's also a big component of customizing care, so true customization to the particular disease, to the stage of illness, to the patient's language, to their sophistication, to their appetite and stage for change, to their style for learning, and all of those plays into what tools or modes of communication we would use. And then I think what we often forget in innovation is that innovation is an ongoing effort, and so we have to continually be evaluating and adapting innovation. And I was just on a call with a group that's doing some innovation in the Northwest today, and they were talking about how they had set aside time in the beginning, a couple hours a week for the team to really think through the processes. And as they've gotten busier, they've lost a lot of that time, and they've had a lot of slippage in their innovation. I think it's really important that we build that priority of having the team building and the process building into the care models themselves, and then have accountability around that as well. I'm going to pause here, and maybe we'll do a deep dive now into what we think is the most critical element, and I'll let Jolene walk you through that.
Thanks, Pranav. Yeah, we had the pleasure of working with Renaissance Health and Boeing to do this, truly innovative model of care at the Everett Clinic. So I will try and keep it brief and stick to the slides as well. We have, first is my cartoon here that is really about primary care current state, and it gets a chuckle, but the truth is that this is actually what it feels like to be us working in primary care. I heard a lot of comments like, we're constantly putting out fires, crisis management, we're burned out, we can't continue like this. So that is capturing that spirit there. Want to talk a little bit about what it is to be a care manager, and a definition I just found in the literature that sums it up very well. Care management is a set of activities designed to assist patients and their support systems in managing medical conditions and related psychosocial problems more effectively, with the aims of improving patient functional health status, enhancing coordination of care, eliminating the duplication of services, and reducing the need for expensive medical services. Some care manager responsibilities. What it's like to be a care manager every day. What do we do? We manage the assigned high-risk population of patients. We assess the risks and needs of each individual. We collaborate with the primary care provider, the patient, and also their support systems to create a truly patient-centered plan of care that we will use as the centerpiece to go forward. We do a lot of teaching about diseases and patients' medications. We are coaches. We are advocates. We do manage to evidence-based targets. I think one thing missing from here possibly is also coordinating care, coordinating the efforts of all health care providers involved with that patient. We ensure that all parties are aware of the patient's medical status and plan of care. Moving on, care manager role. We feel like the crux of the matter really is to build a trusting relationship with the clients. We feel like that was really the secret sauce, so to speak, in the successes that we had in this pilot was that relationship. We do provide access. We facilitate access to the right care at the right time by the right provider. That could also be a community resource group, just plugging the patient in. Having awareness of the services our patients are utilizing, focused on reducing waste or unnecessary services. We also intervene and educate patients and families on how to respond to worsening symptoms in order to avoid emergency department visits and hospitalizations. So really accessing the most appropriate resource for care is a lot of what we did. Okay, moving on. We activate and engage the appropriate extended care team. This is really alluding to a clinical pharmacy, behavioral health. We had integrated behavioral health with this pilot, which was a huge win and a lot of lessons learned from that. It could be a dietitian, a physical therapist, et cetera. You get the idea. Pulling in those people and involving them in the care plan. We monitor treatment adherence and outcomes. A lot of what happens now is people fall through the cracks. There's no system in place to check. So we're actively monitoring that. We are, as care managers, willing to hold providers and patients accountable. We optimize their self-management, as Pranav alluded to. That's really what this is about. As good as we are not managing the patient's health. The patient is managing their health. And right from the get-go, we activate them as an active participant in their health care. And this is different for the patient and can be sometimes awkward and uncomfortable for patient and the healthcare team. It's a different experience. And we feel like it may not happen, right out of the gate initially, but it does happen over time as a result of that relationship with the care manager. Patient-centered care plans. And I like this quote. It is much more important to know what sort of patient has a disease than what sort of disease a patient has. Keep that in mind and post it on our desks as care managers. The assessment tool we use at the Everett Clinic for documenting and assessment is called the 7 Dimensions. This is embedded in our medical record, in our electronic medical record, and we're trying to implement this universally for care managers, looking at the patient's medical and medications, their mental status, functional ability, social support, nutrition, transportation, advanced directives. I won't spend a lot of time on details on that, but those are the areas of assessment. This next slide is alluding to the cycle. Pranav alluded to it earlier as well, the PDSA cycle, plan, act, study, do, of how we do assessment and care planning. Initially we may do a comprehensive medical record review. Then we are talking to the patients. We're assessing them according to 7 dimensions. We're assessing their readiness to change and self-efficacy. We bring them in for a combined visit with nurse care manager, physician. We're all in the same room at the same time. We leave that visit with an agreed-upon plan that we physically give to the patient. However, it doesn't stop there. We're continuing to follow the patient. We reassess them, we modify the care plan, and move forward. And that's just our cycle of how we manage the patients. Okay. The care plan is a result of the collaboration with the primary care provider, care manager, patient, and their family, I'll add. Individualized is the key because all of our patients are different in their preference and willingness for treatment. We're asking them, what they prefer and what they can do. That's different. Everybody has different medical and psychiatric comorbidities. They have different prior history. They have current treatment that's different. We have different responses to treatment. So we're taking all those things into consideration.
We really target the health issues that need intervention with the priority placed on the ones the patient is truly willing to change and willing to do. What's their priorities? We're asking them that. The care manager, coordinates and communicates the plan to all responsible parties, of course, always looping in the patient. And also, just to differentiate between care plan, is not the physician's medical recommendations for care. Although that's an important piece of it, it really is about the patient and what their priorities are. These are some things that our staff and patients have said about the experience with IOCP and care management. Patients say, I've been helped more in the last 6 months than years of seeing multiple doctors. They say, being a patient in the IOCP has been a life-changing event for me. I finally learned to change the way I live and think. I finally stopped smoking. Somebody actually listens to me and is giving me the help I need. I'm out of order here, aren't I? Sorry about that. And last night, my blood pressure is now normal after being high for many years. I'm getting good advice about my prescriptions. I'm able to walk and hope to be swimming again soon. I'm feeling positive now, and I once felt doomed. I feel like a new person. Those are things that patients said. Moving back to the RN care manager experience, our nurses said, we have the opportunity to practice at the top of our scope and truly use the nursing process to care for our patients. Another nurse said, previously I felt like a glorified receptionist, taking messages and passing them along and calling patients back. Very seldom did I feel like I had the time to teach or be proactive with a patient. Again, nurses said, by being proactive, I'm able to get to the patients before their symptoms get worse. This decreases the volume of incoming crisis management calls. And also, as a side note, we're finding very early that it does decrease the volume of calls coming in, period, for these people. Lastly, nursing comment, I get to deal with all aspects of the patient's health care instead of several nurses handling the same issues and not really knowing what is going on with the patient. A lot of waste in our system happens this way, and our nurses recognize it.
Jolene?
Yes?
So we have a question, and I think it's a kind of more appropriate to try and respond to it now rather than later.
Absolutely.
The question is, what is a typical caseload of a care manager?
Sure.
Is there a process to enroll and disenroll patients, and how long does the care manager provide follow-up and how often? So you can start with, what is a typical caseload of a care manager, and we can go through the questions again.
We try to aim between 150 and 200 patients per care manager. And I think Prana would probably, agree. Some of that is just based on, literature from other, best practices. But we also found that with our palliative care program that we have at the Ever Clinic, that is about their caseload. And so we just implemented that. And for now, it seems to be about right, depending on the acuity of the patient.
And then what is the process, or is there a process to enroll and disenroll patients?
The process to enroll the patients in the IOCP model was the patient would receive a letter from us and insurance plan employer informing them that they've been invited to participate in the program. We'd follow that up with a phone call, introducing ourselves, inviting them to participate, and then scheduling them for an initial, what we called an intake visit with their IOCP physician and a nurse present, and then the patient and their family. And we scheduled those for an extended period of time, 45 minutes to an hour long per patient. So that's kind of how we enrolled them. Does that answer that?
Yes. And then
okay.
the last question, this was a multiple question, had how long does a care manager provide follow-up and how often?
That is going to be largely dependent, of course, on the individual. We don't have, a standard per, patient, but we really feel like the minimum amount we would contact a patient would be once a month. Again, generally speaking. But we feel like if they truly, don't need us and we're not needing to contact them, or it's not a mutual exchange of benefits, then we feel like we would consider disenrolling the patient. Just, again, really individual dependent.
Great, thank you.
Sure. Okay. Physicians would say, I have uncovered many details about my patients, some of whom I have known for many years, that I never knew, and I'm able to treat the whole individual. Another doc said, taking a step back from the rat race has allowed me to develop meaningful relationships with my patients. And then another physician said, previously I used my MA as a nurse and treated our office nurses like clerical staff. I really was not aware how much the RNs could help with the care of my complex patients. They're all Everett Clinic physician comments. This I wanted to include because we did what we call a rapid improvement design process at the Everett Clinic in January, where we took this IOCP idea and decided we wanted to implement this clinic-wide for some insurance plans who wanted to work with us to implement an IOCP-like model. We involved patients in that planning session, and this is some artwork from our patient, and this is how she saw the current state of her health care. Here she is. She's a concerned, complex patient. And here on the other end is the physician. What you can't see is the nurse and other medical assistant care team up above there. But the patient felt like she was calling. She was speaking with an unprepared nurse who doesn't know her individual situation, medical history. She is instructed to make an appointment with a physician who unfortunately does not have enough time to sort out the complex issues that she's having and refers her to a specialist, or orders a lot of expensive lab testing, and there's no consistent follow-up. The dollars in the middle, she felt like represented the disincentive, so to speak, to take the time to sort out her chronic complex needs and kind of move her along in the system and see somebody else who is less acute. And that was really wise, I thought, and that was her perspective. And then she participated in IOCP, and after IOCP, she felt like, here I am, complex patient, but I call an informed and proactive care manager nurse who is familiar with her. She has a relationship, knows her health history and current situation. She felt like care manager could make a good, informed decision about where to refer her. In this drawing is walk-in clinic, hospital, rehab, or SNF. And in the care manager's head and heart are all the aspects of the patient's health care. And she just wanted to represent how all of these entities and things to do with her health care could be channeled through one person and lead back to her nurse care manager. Nurse care manager is the source of input and output for all those aspects of the patient care. And she felt like the big difference was having a prepared, proactive team who was on her side. So I will end with that. I guess we'll turn it back over to Pranav to finish.
Thanks, Jillian. That was great. And we really find in all the work we're doing that the care management piece is what the patients like the most, and we think that's the critical additional element that's making a difference. And just coming back again to the IOCP evaluation highlights, it's what Everett Clinic and Virginia Mason and Valley were able to do with the AICU model and their implementation of it really was impressive. They were able to reduce the overall spend, and it was primarily in the ED and hospital utilization, and a lot of that is in that care management relationship development. So patients were calling Jolene first before they were going into the ED. Often we'd have stories of that. Patients were, because of Jolene and others, proactive outreach into patients. And when we say proactive outreach, the rule is that the patients are contacted at least monthly, and most of them much more frequently than that. And they use a lot of email. And so patients, we were finding problems before they escalated to hospitalizations. And so the right kind of mix of utilization we see is a decrease in hospitalizations, a decrease in ED visits, with a corresponding actually increase in pharmacy. There's higher compliance levels showing high engagement levels, and then some moderate increase in outpatient visits. And that really, I think, is the key when we look at it from a purchaser perspective or a health plan perspective, and also from a primary care perspective, which is, there isn't any new money for primary care, but if we can show that primary care can drive down downstream higher cost spend, there's probably a reason to resource primary care to be able to do that. The other 4 points of the STAR we talked about on the previous one, but I thought I'd double click on the utilization. So just looking quickly at what the early lessons have been from these first implementations. Patients and providers loved the program, as was clear in Jolene's quotes that she had. I think there's a lot of optimism that we can reach IHI's stated triple aim and the plus categories, and there's starting to be consistency in results reported from Geisinger and Hopkins and others who are doing similar models of care. The key setup element here, though, is the partnership between the payer and the provider, and there has to be an alignment of incentives in order to make this work. There has to be a true spirit of collaboration in this. And then we have to have really different care processes. There has to be an intentional approach, as Jolene talked about, the intake visit, and then the care plan, and then the constant oversight of the care plan to see if we're on track, and then to create high self-efficacy in patients by giving them small, frequent wins against the care plan so they feel like they're achieving, and then creating sort of a sensible rollout of these things and getting support from the physicians and other providers in order to get high support at the clinic level. The relationship is the key. In all of this, our paradigm is that it's about behavior change. The patient changes behavior, the provider changes behavior, the health plan changes behavior, the purchaser changes behavior, and that's all about relationship. We need to get trust, and in order to do the things that we know scientifically that are correct in terms of clinical care management, we need to be able to do the things that behaviorally are correct as well. And so even in our early stages, and Jolene can probably speak to it, but our recruitment rates were far above traditional telephonic disease management, where it's an unknown entity, so embedding it in primary care, we were getting higher than 70% engagement levels. While this can be done wrapped around many providers, we certainly think it's smart to focus initially on small, dedicated teams. Culture is a big part of this. There has to be a lot of planning, especially the first time out. In a new market or with a new medical group, there is a fair amount of work that goes into it. And then in terms of IT, I think it's not the magic bullet. It's a component of this. And the key pieces here is that you have to have capable disease registries and disease tracking so you can do the follow-up in a proactive way. And then having health plan data is critical in order to select patients and create profiles using utilization data. And so finally, just in closing, and I think the only real way to improve the performance of our healthcare system is through a fundamental redesign of the care process. And there's a lot of efforts out there, and medical home is a buzzword right now, around kind of redesigning all of primary care. I think there's some ultimate need to transform all of primary care. And if you think about what maybe might be the cornerstone or the foundation, probably taking the folks that are the primary utilizers of healthcare and of primary care, to be honest, and focusing our intentional efforts on them as a starting point and creating kind of that cornerstone to the whole structure. Providers alone have not been willing to do this. We need to do models of care that can really be win-win-win-win, so the quadruple P's win, and really then catalyze ongoing redesign. So the IOCP is one model that provides some evidence-based, peer-reviewed support, that there's ways to provide better and cheaper care for the sickest members of the population. And the potential cost savings are pretty big. Over 20% reduction in the Boeing model. We're seeing some similar declines in other places in terms of ED visits and hospitalizations. Most of this work is fairly groundbreaking, though, so there isn't a lot of data already out, but stay tuned. What there is, though, is a lot of momentum in the marketplace, a lot of urgency towards doing things. I think there's support from some of the federal health reform around building things that are called different names, but accountable care organizations, medical homes, chronic care models, and Medicare putting additional funding into their own demonstrations. Real close to home in California, the Pacific Business Group on Health is actually leading an initiative to roll out an ambulatory ICU demonstration in 2011. So stay tuned for more of that, and California Healthcare Foundation will probably be involved. In Oregon later this year, they're going to roll out a statewide high-value medical home is what they're calling it initiative, which is a derivative also of the AICU. In Washington, they're now expanding. The Boeing IOCP and the Everett Clinic in Jolene are leading that work. And then nationally, Geisinger, Hopkins, others are doing some focused complex chronic care management. So I think there's a lot of excitement and a lot of great movement here, and hopefully, 5 years from now, or we can all look back and say that there was some sensible steps we took to make a little bit of difference in creating a more sustainable healthcare system. So we'll pause here, and happy to take questions. And Karen, maybe you can lead us through that.
Sure. So if you have a question, feel free to virtually raise your hand. I think the button is kind of below the participant list, or you can send me a question via the chat function. We have a question about what happens to patients with pre-diabetes or patients with less high risk, such as ear infections, sore throat, etc. When they call in, who triages them, and how much time do they get for an appointment?
Yeah, so that's a good question. This model, the AICU model, is explicitly focused on folks who have been predicted to be in the future highest top quintile of risk. And so to the extent that one of those individuals calls in, they move through the process in the AICU manner, which is they'll get their advanced access and they'll get direct access to their nurse care manager. So Jolene or somebody at Everett Clinic would directly help to facilitate what needs to be done with them. If they're not in that top 20% of future predicted risk and they're not in the care model itself, in this model they would get usual care. What we do see is a lot of spillover effects. So we're doing a project in New Jersey, and we've seen a real marketplace shift around how primary care is delivered in terms of access and scheduling. So we're seeing a significant decrease in wait times to third next appointments and to acute visits, just from the notion that a purchaser came in and built one of these AICUs that delivered really high care. The other physicians in the community said, that is the right thing to do. But that's not an intentional focus of the AICU, which is the folks that would fall in the lower 80% of future risk.
Great. Another question we have is, would you please review the reimbursement model? And then after that, Bobby and Tweety and Jerry Penso, I'll unmute your line so you can ask your questions directly.
So the reimbursement model we used in the Boeing IOCP was providing the medical groups with the regular fee-for-service and then a per member per month care management fee. And that worked out to about a 2% of the spend of that population. So Boeing hasn't really released those care management actual PM dollar amounts. But effectively about 200 patients would pay for a nurse, which is the direction of the reimbursement. Future models are looking at a 3-tiered reimbursement model. So that's the fee-for-service plus the PM care management fee plus a share of the savings between the sponsor and the medical group. And I think the principle here is that we want to make the medical group whole on the additional investment that they're making. But the real margin for the medical group and the upside for them is around that shared savings. So if they can produce equal or better quality and they can show significant cost savings, there could be a pretty big return for them.
Thank you. Bobby, do you want to ask your question? Well, Bobby also sent a question via chat, and it was, what are the key components of the IOPC that differ from the home model? Are they the same?
From the medical home model, do you think?
I assume it's a all home model with all caps, but I'm assuming it's the medical home model.
So if it's a medical home model, I think the paradigm principle number one that's very different is that it is really focused on the sickest part of the population, and it's intentional as a starting point for some broader transformation, but also the place where we're going to get the highest return on the upfront investment. And so I think then it really is this intensity of effort that happens for these sick folks. I think of it really as a cornerstone of what ultimately could be the way primary care is done, where we ought to actually focus a significant portion of primary care spend on those individuals. So you could see a future state where medical home, by whichever definition is preferred, is done somewhere, but a big component of that is something like an AICU or an IOCP, where there's a real focus on the complex and chronic individuals. And I think that it's a synergistic thing and probably not a differential thing. It's just a different focus or a different intensity of the lens.
Thanks. Dr. Penso, would you like to ask your question?
Sure. Thank you very much. My question deals with the role of the primary care physician. I'm wondering if you could describe maybe as specifically as possible what they did differently. Did they have to change their schedule? Did they have to use special forms? Did they contact the patient frequently? Did they have weekly conferences with the care manager? If you could be as specific as possible how their work changed.
Jolene, do you want to talk about how you guys are doing it in the new Everett Clinic model?
Sure, I can. What we're doing, now, moving on from IOCP, is embedding, care managers directly with the patient's existing primary care providers. So we do work a little differently with primary care physicians, and our physicians, of course, are, trying to figure that out, concerned about reimbursement, all those things. Early, learnings, what we've found is we are giving the patient some extra time on the physician's schedule. So we'll usually book an IOC patient for a 30-minute visit. We will have the nurse do upfront, checking in, pre-visit planning, backing up a bit, pre-visit planning, checking the patient in physically when they come into the office, having a combined visit with the physicians, and the nurse is in the room with the physician, and then wrapping up the visit on the tail end after the physician exits and clarifying the care plan. Thus far, the interaction with physician on a day-to-day basis hasn't looked a ton different than it does, currently, as far as are we needing to interrupt the physician's flow to ask a lot of questions? No. Are we having scheduled, weekly conferences or huddles or anything? Not yet. We have not had the need for that yet. Also, I'll let you know our panels are very small right now. We have 4 managers. The biggest panel is 50 patients. So a lot of that will probably be unknown. I'm not sure if, Brian, if you have anything to add from other, learnings from VM or Valley, but really what we found is the physician's work outside of that, extended office visit hasn't been impacted a whole lot yet, except for positively in the fact of higher patient satisfaction and early, outcomes.
Yeah, so I'll add to it a little bit from a few other sites. So I think ultimately, if you think of the RN care managers, 200 members and a physician maybe having at most, and this would be at a really high end if a physician has sort of 100 or so of these members, but most physicians, if you're spreading that across 4 or 5 docs, are going to have less than that, so in that 40-50 range. It doesn't on a day-to-day basis really change what they're doing. A lot of things that the physicians would have had to handle in terms of phone calls or messages from their staff or prescription refills, or so-and-so ended up in the ER, can we follow up on that? It ends up going through that RN care manager and gets leveraged much better, and then they do internal office communications to the physicians. So our physicians will say they do a lot of internal office communications with their care managers around what's day-to-day activity going on with these patients who are in the program. In terms of the visit, they do try to couple visits so that the RN care manager has time with the patient next to the physician office visit, but it leaves the physician office visit the same length, but much more efficient. I think across the board, our physicians would say that they're having stronger conversations with their patients because their patients are more in tune with what's going on because of the prep work that they've done with the care managers. So I think our docs, initially there was some fear and concern that this was going to be disruptive to their schedule and reduce their productivity, and most docs are paid by productivity. What ultimately happened was that they felt that they actually got more productive visits in an efficiency sense. And so that's one model. That's the IOCP or AICU embedded into the primary care office. There is another model that we didn't spend a lot of time with, but it's an AICU where we actually set a primary care doc stands alone as an AICU, and actually patients gets referred to them. So if there's a group of 8 docs, maybe one of the docs becomes the AICU physician, and these patients get temporarily referred over as they would in a specialist visit sense. And then that team is sort of isolated and dedicated on the model. And then, of course, the care changes quite a bit where that doc is exclusively doing AICU work. And that model is what we're doing in New Jersey, and it's actually in the purest sense what the original AICU was. But we've since evolved to mostly having embedded care management into primary care.
Thank you. We have a couple more questions that relate to the original question that Dr. Penso asked. One is, what is the potential additional capacity of the primary care physician panel size with this new model? And then the second is, do each of the 150 patients that the care manager has, do they each have a care plan in place?
So I can take the first. I guess we don't really think of this as increasing primary care capacity. Some of our doctors have said that it probably would, that what they've called it is a career extender, because they've had a slightly lightened feeling on their shoulders about not being able to manage these folks well at the end of each day, feeling that they should have been doing things that now the care manager helps to facilitate, either doing by the care manager or by the primary care doc. There probably is some incremental gain that we could have in primary care panel sizes, but that's not necessarily the intention of this particular model, and so we haven't measured it in that way. Jolene, do you want to talk about the care plan for the folks? Does everybody have one?
Yeah, absolutely. And just to tag onto what you were discussing earlier too, one of the physicians I work with in the IOCP model, one day actually approached me and he was like, "What do you do all day long?" He's like, "I don't hear from you a whole lot, and I know you're managing the patients, but what are you doing?" And so I think that kind of spoke to the fact that instead of causing, further interruption, disruption, fragmented care, it actually turned out to be less work for him and less burden off his shoulders, that career extender idea. I think he would agree to that. Care plans, yes. The goal is for every patient on our panel to have a care plan, and it's one of the metrics that we're actually tracking now at the Everett Clinic. We would like that to happen within 30 days of the patient, being enrolled in the program. We would like assessment and care plan to be done. The vision is to have that initial intake visit, which is a combined visit with nurse, physician, and care manager, for that to be kind of the care planning visit, kind of whole comprehensive overview of the patient, where care plan is developed and what the patient's care will look like for the next, several months is kind of outlined there. So that is the goal.
And then we have another question. Are there any demonstration projects with the Medicaid and or Medicare population currently happening?
So that's a good question. In the new reform legislation, there's a lot of openness towards it, and they've actually moved some of the previous requirements that literally were an act of Congress to get some of these demonstrations up. Now they'll be able to be kind of come out of Sibelius's vector or vertical, if you will, so she can create demonstrations, she can participate with demonstrations. At the end of 09 or really early in 10, CMS said that they wanted to participate in up and running demonstrations, so that they were going to look and see what was going on in terms of medical home and play a role in that. There hasn't been a ton of specifics around that yet, but there is budget to do those things. In terms of Medicaid demonstrations, there's actually several around the country, and we probably don't have a lot of time to go into it, but in Vermont, if you look at their medical home demonstration, they actually did a focus on Medicaid and the sickest part of Medicaid. Care Oregon is actually rolling out essentially distributed AICU, so doing an intentional AICU around their sickest part of the population, but they're going to have the care managers sort of move from practice to practice. It's not ideal, but it sort of fits the population and the migration of that Medicaid population. And then North Carolina, they have some good data around Medicaid population as well. But that's probably a great topic for a whole nother call, Karen.
Yes, and we have two more questions. I guess maybe quickly, if you can respond to what risk stratification was used to select the target patients, and then I'll try and connect you with the person asking the other question of who else can do care management. If you have to go, we can connect you after the presentation.
Yeah, I can probably answer both. The risk management, what we typically use is a predictive risk modeler. So DXCG, MedAI, Ingenix, they all have tools that roughly do the same thing, and they're roughly right and wrong about the same time. Symmetry has a grouper tool that they use. So we look at the population, we run a predictive risk model against them, and we identify who the future highest risk individuals are. That list will go to the medical group, and then the medical group does some selection clinically of who the right candidates are. And we think of it as elasticity, so which candidates have the highest elasticity in terms of their disease and in terms of the opportunity to help them in their disease. And the other piece we're looking at is where can we mitigate just the regression to mean phenomenon. So the medical group looks and selects patients who they think truly have conditions that are leading to high future risk and not just regression to the mean. In terms of who could do care management, I actually think probably a lot of different roles could be there. So the nurse, certainly social worker in some situations, pharmacist has played out well. Health coaches and community health workers we've used, particularly in some of the low-wage, under- and uninsured populations. If we were to kind of just say line up groups of those professional capabilities, the highest hit rate is in nurses. They seem to have the right culture, the right clinical knowledge, the right respect from the physician and physician extender providers, and they have the right relationship skills with the patients, and they can manage multiple complex conditions. But each of those other, I think, segments play a really, really important role. And in some ways, if you could build a team with, at scale, you can have all of those pieces there so that Jolene can really focus on her nurse care management role and have social work and behavioral health and pharmacy play supportive roles with them. But I think that other models are out there, and this is one example of it, but we think it has the highest hit rate.
Thank you, and thank everyone for joining, and thank you to Dr. Kazari and Ms. Rogers. We will send the recording and the PDF of the slides later today, and if you have further questions, feel free to contact me or Dr. Kazari or Ms. Rogers. Their contact information is up on the screen and will be the last slide that's sent out. So thank you for joining us, and have a great long weekend, everybody.